All right. Thank you, Kristen. And thank you all for joining us. Today, we're delighted to have Terri Wareham with us. Terri is a graduate of the GSB, there was the GSB report booth. She's a graduate of our health administration program. So many of you may not know, but for about 50 years, we had housed in the business school the world's greatest hospital administration program. And Terri is actually a graduate of that program with her MBA. She's managing director and founding partner of Kaufman Hall, which is one of the premier, if not the premier, healthcare consulting firms in the United States, international. We can hope some, but doesn't. Oh, well. And was founded by actually three boot club. So we'll get into that a little bit. And her clients range from community hospitals, AMCs, multi-hospital systems. She's a frequent lecturer and author on healthcare capital related topics. Anyway, let's welcome Terri. So tell us a little bit about your background. Where did you grow up?
I'm going to project, because he said I had to project back in the wide range. I grew up actually outside of Chicago. The all important part, I went to Wareham undergrad as a biology student, did research, thought that's what I wanted to do, or med school, and got to my senior year and was like, I don't know very much. And my advisor said, how about healthcare administration? You like that medical side of it. So I applied to a few programs. I selected the GSB because the healthcare administration program was part of the MBA. On the side of that gave me a broader depth than like a master's in public health or master's in management. So I was all of 20 years old when I got here. And I was here about 3 seconds and thought, oh my God, number one, how did I get in here? And number two, everybody's way older than me and I have no experience, right? These were people that had been out and about for, 5, 8 years, some longer than that. So I knew I needed to do something. And there was a job opportunity. It was a firm called Health Facilities Corporation. And my partner, Ken Kaufman, was the executive vice president. Ken also went, as Tolan said, graduated from here in 77. And they posted for an internship. And that firm did the capacity studies, feasibility studies. There was a lot of rate regulation at that point, certificate of need, helping hospitals do those things. So I interviewed for that job. I got that job and never looked back. That consulting and helping healthcare organizations in that regard became my passion. And I knew that right away and abandoned the whole hospital administration concept, much to the chagrin of the guy who ran the program here. And I worked 20 hours a week during my first year. I worked there full-time during the summer in between, and I worked 30 hours a week in my second year. So don't ask me really what classes I took because I don't remember a lot. We kind of very busy. The firm was up in the northern suburbs. So, and doing the hospital administration program at that point, in the second year, we had to do what they called a practicum. And I was at Resurrection Hospital, because out on the way to open there. It was a busy year. I learned a lot. I loved it. And I went to work there full-time. Mark Hall was a 78 alum. No, Mark is 77, Ken 76. Went to work in health facilities also. Now there's a backdrop here, and I want to call it one durable. The backdrop is that healthcare performance systems will change. Yeah. So this is early Navy, the federal government figured out it was gonna run out of money for the Medicare program because they used to reimburse hospitals and physicians for their costs. So hospitals and physicians were incented to do more volume, more tests, more procedures, more visits, and it was completely inefficient. So the government decided to move to what's called the prospective payment system at the time to limit the amount of money it was reimbursing hospitals and physicians for care. And that really shifted the whole not-for-profit healthcare sector into having to become businesses, which they hadn't been prior to that. So Mark and Ken and I in 1985 left Health Facilities Corporation to start Kaufman. We want to really the original executive was to apply corporate finance principles to the not-for-profit healthcare sector. We did. And we started with the three of us. We had one shared office space with 3 phones and 2 desks. And if you look back on it, it was sort of the true entrepreneur, the models are more right? And that everything kind of still on individual. A lot of that kind of stuff as we were building the business because we had no name recognition. And a lot of hospitals, even at that point, were understanding how financially focused they had to become to run. And so that's really been the base of the business. And it's a little bit of, find a need, fill a need, and finding what could be helpful to our clients to help them succeed. So our first product was actually acquisition of debt capital for expansion. So what does that mean? It means, and right now we're actually the #1 financial advisor to healthcare borrowers nationally of tax-exempt debt. And what we would do is help our clients understand what their project was, what it was going to do, and then how to tell that story to the capital marketplace, whether that was bond rating agencies, that was investors. It's kind of interesting. And a lot of this you have to personalize, right? You're going to go borrow money. You have to prove to the lender that you're going to pay it back. We were, once Medicare stopped paying funds, they had to show profitability and show an investor who was going to buy a 30-year tax-exempt bond how they were going to pay it back, right? So now imagine there's 3 of us and we're focusing on that portion, and it led immediately into how do you tell a credit story is, financial projections, debt capacity analysis, the financial side to feed into the capital acquisition story. And after a few years, so it was teaching corporate finance to our hospital clients. And then that, though, financial plan is supported by a strategic plan. And what we were trying to do was help our clients match their financial capability with their strategic plans and directions. And we knew we had to build out a strategic planning effort because what we were finding was a little garbage in, garbage out of client developing its own strategic plan or hiring a firm to do it, and we were in sense. So we built out, and this is, I talked about this last week, as we grew the company, we built out organically what we needed, what we thought our clients needed. So kind of point #1 is you have to look ahead to think about what are you projecting their needs to be, and building around that to try and fill those needs. So we built a strategic planning practice, which could then fold into our financial planning practice, which then would help our clients tell the story and apply their debt capital at the lowest rate. So as the years proceeded or continued, a number of other things are happening in healthcare. And one is that patient care was changing rapidly in a good way, right? For technological advances, but it was taking care out of the 4 walls of the hospital and putting it elsewhere in lower cost settings, right? So, my story is that, in high school, I had a hernia and I was in the hospital for 5 days. I had one as an adult and I was in for 4 hours for an outpatient surgery. That affects the hospital, right? You could have 300 beds and all of a sudden you're filling 100 of them. because all these patients are being taken care of, better for the patient, not so great for the hospital. So the dynamics, right, continue to change. And I guess this is why I don't, man, obviously I'm passionate about it, but like it's how do you balance that equation as it continues to change? And we could talk about this too in a little bit, you know, AI and all kinds of things that are changing the way healthcare is delivered or will be delivered. But you still have these hospitals that are bricks and mortar, really expensive equipment that need to be supported by other cost basis. How do you continue to pay for that? So as we continue to look forward at what our clients need, we built out a merger and acquisition practice because hospitals were closing. Because you didn't need as many, right? You don't have as many people going into the hospital. You don't need as many. Then not many boots your thought everybody survives. So we built out a merger and acquisition practice. Physician alignment became much more important because, to be honest, patient doesn't really pick the hospital. They send the doctor. And the doctor sends the hospital. So the relationship between the physician and the hospital is almost more important than you want the patient to have a good experience, but it's the physician who starts at the tip of that spear. So we built out a physician enterprise, as we call it, and we've continued to add on to that as well. So in our financial planning practice, supported by the strategic plan, let's say, okay, hospital XYZ, you need to make an X% margin and do this, that, and the other thing in order to execute and fund your strategic plan. And at a certain point, clients turned to us and said, okay, that's great. You're telling us what to do. Now tell us how to do it. And we built what we call a performance improvement practice to help answer that question for the client. So these became people that were much more clinically based, much more integrated into the actual operations of a hospital. But people who could help them sit down and say, how do we make this better? How do we improve our cash flow? And over time, we went out and then began inorganic growth, where we bought a company called Claro, which focused on revenues, on clinical documentation improvement, because you can't shrink yourself to success. It's not all about expenses, right? It's about optimizing your revenues. Again, this isn't just healthcare, this is any company, right? So we went out and we did acquire a company to help us do that. It's been very successful. It's amazing. I know you read about it, how much inefficiency there is in healthcare that can be improved upon. So we bought that, and we also bought a couple of supplemental companies, software companies. We built a software product to support, or it started out Lotus 1, 2, 3 and Excel. Anybody know what that is? Probably not.
Excel, they know.
They know.
Yeah, but not Lotus.
There's a calc that actually started.
There's a calc, yes.
A software product to support the financial projections and some of the cost accounting and to be able to help debt capacity, strategic planning, to help our hospitals with a tool that you could leave with them and say, okay, this is what you use, because we don't want it, as much as it was great for revenues to be like a tenure or continuing, really it wasn't what we wanted to do. We wanted to make self-sufficient.
How many hospitals did you install it? How many hospitals were using it?
About 1,500.
1,500 hospitals. So
we did sell that product because we're not software people. We're in a software division, but we did, and we work with the same company to use the software.
So give us a sense of the scale of Kaufman Hall now.
So we have, sorry to interrupt you. We have at this point 700 consultants. We were acquired last August by Gazient, which is about $2.5 billion, I think. It's a group purchasing, sort of a spend management company. And we had worked with them. They became a strategic investor in Kaufman Hall about 4 years ago. And because Vizient has oodles and oodles of data. And you guys know this, right? It's all about data. And, you know, you don't want to be data rich and information poor, but they are data rich. And we in our consulting practice love having the data to support the information on the consulting practice that we have. So it was really, it's very exciting for me to have us be their consulting business unit, because we can use their data. We can work with them for them to help shape it the way that we need it, that would be most helpful to implement.
There seems to be a lot of synergy between Vizient and Kaufman Paul, as far as I can tell. Before it was Vizient, it was what they call it, just UHC or UHC, and it was sort of so they had members of all of these, you know, academic medical centers, and they benchmark each other and share lots of data together. But as part of that, they do a lot of, you know, there's a lot of need for their own members for Kaufman Hall services. Right. So it seems like it made a deal. How'd you get your first clients? How did it start?
So when we left health facilities, we had 5 clients come with us.
Okay, took them from there.
Yes.
And they weren't interested that the health facilities corporation wasn't. They weren't doing the finance stuff. So
no, the gentleman who owned that company just didn't see it coming. He liked to make the money doing what he was doing. And this was that look ahead. Right? You have to look ahead and think, what's coming the train when you look at the tunnel, or I can see a little light. And this is all going to go away. And when part of what happened was Medicare was reimbursing hospitals also for capital, so they can spend. And they can spend, and that's part of why they had these big facilities, right? And they go virtual in the 60s.
So do you think the DRG system worked?
Oh, I think it did. Did it work? It caused them to refocus. So yes.
Yeah.
Yes. That perspective.
Refocus. So you think it impacted volumes?
Really? Yep. Well, as I said, so Medicare had been reimbursing based on volume. More things you did, more money, more left big. You didn't need a scan. You needed that they were ordering the name.
Okay, and so what are some of the trends you're seeing in healthcare now? What's happened? Just some of the hot button topics.
So as I said, the continued movement to outpatient, to away from the hospital. So the sickest people are now in the hospitals.
Yeah, yes, the ambulatory surgical centers and all
the outpatient centers. Yes, and that triggers because those are lower cost settings. Right. That triggers this discussion about site neutrality and reimbursement for that. I don't know if you know what site neutrality is, but you know, hospitals generally charge for procedures and activities at their main campus at their main hospital. They charge higher rates than if you have something done at an ambulatory center elsewhere. And the government's like, I think there's a pot of money there. We should just pay the same amount for everything. And that's an issue. So now I'm race here for some. So hospitals have emergency room, which means they have to staff surgery 24/7, a lab 24/7, radiology 24/7. Well, that costs more than an ambulatory surgery center that's open from 8 to 5, and they'll have your procedure and your call. If you're really sick or you have something complicated, you're not going to have it done at an outpatient center. You're going to have it done at the hospital. In case there's a comorbidity, or you have a heart attack, or you have something during the procedure. So it's, in my view, it is warranted to have a higher rate when you're having it done at the facility. But so you asked about trends. So site neutrality.
Yeah, you think that's going to happen?
You know, I think there's enough of a push that.
Think so? Yeah.
Like AI, so the movement to outpatient, which is significant, movement toward value-based care, which of course, why not, right?
Yeah.
You know, So then, we're not always want as much of your money as possible. I think private equity.
Yeah, what's happening there? What do you think? What's your view about private equity? I don't think many PE firms they're sort of not buying hospitals so much, right? Well, yeah, what does that tell you?
So the private equity firms and the large physician groups are, they're looking for cash flow as well, right? So they're peeling out the profitable business from the hospitals. And so that's also happening during this period of time, right? And reducing margins at hospitals, great for them. Walgreens, they get into the primary care business and they're losing their shirts, so they stop doing it, right? Well, they could do that, but hospital can't.
Hospital can't, yeah. What's been happening with these like storefront, retail, the Oak Streets and all of that? What's been happening on that side of the business?
They have their issues. Some are successful. It depends on the payer mix.
Yeah.
Which is, are you mostly Medicare or Medicaid or commercial insurance? Everybody wants commercial insurance. Hard to make money from Medicare rates, and you never make money. So there has to be enough commercial insurance business to support.
Yeah, so it depends on where these facilities are.
Exactly.
Yeah.
It's aware.
And then, Medicare is now half of it's now Medicare Advantage. Do you think it's going to continue to grow? Going to shrink? What the trends are with that?
I think it's gonna shrink. I will tell you that a lot of our clients are getting out of Medicare.
Yeah. Why?
Because they're losing money.
Why are they losing money?
It's the way that it's set up. It was set up to save money.
Yeah.
No, that's it. That's the end game here is that Medicare Advantage was set up to reduce the amount that federal government needed to pay for Medicare patients. That's it. It's just the amounts don't cover it.
They're not
balance here somewhat.
They're not covering it. Yeah.
Covering it.
Do you think they did? I mean, there was this MedFact report showing that there was they were actually paying a lot more, right, compared to Medicare. And when I saw that, I thought, hey, this is probably the end of Medicare Advantage, or it's the end of the party, let's just say.
Right.
I'm sure. And then we should talk about AI. So there's a lot of the thing that's been in the news lately is how everyone is basically turning to AI because you can't get an appointment to see your doctor. Which, by the way, we're going to fix that this winter. They're going to fix that this winter because we're doing a project. Anyway, but because you can't get an appointment, people are going to the AI chatbots now. What do you think about that? That kind of
AI is great for scheduling. So on sort of the non-clinical side, when I think that healthcare providers are trying to embrace that as they can. And again, go back to the physicians, you can only embrace that as quickly as the physicians will embrace it.
Yeah.
And there's a fair amount out there that don't want to change what they did before.
Yeah.
It's a slow process. But there's a lot of opportunity there. I think it's Jefferson Health in an article said their chief innovation officer said they were looking to reduce the physician time they spend on administrative stuff by like 10 million hours a year or something. And it's like, a couple hours a doc by AI doing better things for clinical documentation and patient scheduling and some of those types of things. The blurry area in healthcare, so it's okay for administrative things, but going into the clinical side, it's a lot scarier. And because there's bias built into a lot of models, there's data that isn't comparable necessarily to get any. And so there's patient safety and security, but you have all these models out there now that it's like you can go order your own tests, request a LabCorp, and then what do you do with that information? It's a little scary to be thinking that you can arm people with this information, they're going to do the right thing. So there has to be a better connection and a better governance system for AI in healthcare.
Who's going to do that? So do you think primary care is going to get disintermediated to some extent?
No, actually, I think primary care will become more important.
You think so? Okay.
Because you're going to have people doing this, and they should get connected into their primary care, who should be the gatekeeper.
Yeah.
Right.
Right. So you need
that's the theory.
You need the AI to drive the primary care visits.
Right.
Yeah, that would be the goal.
Right. Because in that case, sometimes they'll look at it and go, yeah, no, you don't have to.
Yeah.
You don't have to go here. I think that it will re-enhance the PCP.
Yeah.
Which we got away from for a while.
So there's been a lot of AI models, some of like the Epics, the EHR companies have their own AI models and whatnot. Are they working on these chatbot things too? Do you know it? Yeah.
Yeah. They're trying to make them smarter. Yeah. They're trying to put governors on them, so if people ask certain questions, that it hits an agent.
It's an agent.
It says, okay, talk to somebody,
right,
instead of continuing. So I think that's that whole governance, right? If it's okay to have a process as long as you keep it the band of success.
Yeah. Well, we'll open it up to questions in just a minute, but just in thinking about, you've just been so successful with Kaufman Hall as a consultant, and a lot of our students are, they're really interested in becoming consultants and working different sides of the healthcare industry and whatnot. What kind of advice, suggestions, what you have for them as they embark on their insurance?
So it's kind of two-pronged. One is healthcare specific, and the other is consulting. Obviously, I love consulting. I love telling people what to do. That's jokes. So what really intrigues me about consulting is the job of a consultant is to help a client find a solution. That's a lot. Building a donut shop or a gas station or whatever. It's trying to get behind it to help somebody over the side. Or make it a widget. You want to make a widget, that's not it. It's intellectual capital. And that's what drew me to that. Rather than being inside an organization, I liked seeing multiple situations. And that's a difference as well, because I have friends who are clearly, either in administration or they're in one organization, and they prefer that because they feel they have more control in what they're doing. From a consulting standpoint, you're out here. You're not in the inside. And that's a difference. Just something you have to figure out what you like. I think from the healthcare side, it's just changing all the time. It's been 40 years worth of watching things change and trying to help our clients kind of dart and weave and evolve with the way patient care is changing, the way the payment system is changing. It's not all just about how you run your hospital. It's within all these other clouds of change that are happening around the organization. I think it's look to find your passion, right? Where do you think you'll be comfortable? And maybe I'll ask some of you that question. What kinds of things are you thinking about? Because in healthcare, there's a giant continuum of options. You can go into operations, you can go on the payer side, you can go on the tech side, which is right now, we're building out an M&A in our M&A business, the ability to do tech transfer transactions. So it's kind of see what's out there, right? Follow where you think it's going. That answer that question?
Yeah. Well, no, that was good. How important do you think it is to have some exposure to what's going on inside hospitals?
Oh, I thought the practicum that I did was amazingly helpful.
Yeah.
amazingly helpful.
What was helpful about it?
Because you could see how the inner workings of what affected what. It wasn't just, it's really good to understand the inner workings of something, because then you know how to apply solution. We had to do, it was set up so that you spent a couple of weeks in one department, a couple of weeks in another department, a couple of weeks in another department, and then kind of do your own evaluation. But it allowed me to see, who reported to whom and what affected what, how linen delivery affected the ability to keep the beds open on a certain unit, right? You don't have any linen, you don't have the beds open, because you can't put the patients in the bed without the linen. But it may seem simple, but when you see it, it was up.
Big hospitals are among the most complicated organizations run anywhere. Really. And then you layer that, and you layer the whole, insurance, payment stuff on top of all that. And it just becomes just a crazy complicated business. Okay. Any other thoughts before we open it up? Things you want to share?
No, I think, and we can talk about this at the end. It's kind of, just be patient and find what you think you will like within your own risk tolerance. So when we started Kaufman Hall, I was 25. I wasn't married, had no kids, and I could take that risk. And even when you go into a particular, a company that's already in business, you go to a McKinsey or you go to a Booz, or somebody, BCG. You just have to, you have to try and get your head around your risk tolerance, right? And how much you want to work, where you want to work, what's happening. Dear friend whose daughter is, becoming major league at JP Morgan, and she's tired. Talked to her recently, and I was like, okay, I kind of did my thing. I'm not sure I want to, be as broad as I am and traveling international. So I think you just have to figure out some of that, right? And listen to everybody, listen to what other people are doing and what they're thinking, because that will help figure out what you want, where you want to be.
Okay, that's great. Thank you. All right, so open it up to the students.
You want to talk about it?
Yeah, what's on your mind?
I have one question. So, because right now AI technology can do a lot of data analysis stuff, that giving to some information to the AI, and you can give a lot of for example, consulting that strategy for your data or the entry level we think it's for the students who want to get an entry level CA consulting. Do you think the students still have competitive advantage compared with AI right now?
We are going to see that. We're going to see entry level jobs going away. That's those things which at Kaufman Hall, we are trying to focus on training of sort of the junior staff, and that's hard because the more that gets replaced, harder it is to understand. You put stuff into a black box and it comes out, and then you less understand how it got there, how it got out. I think that's an issue that companies are going to have to deal with, because the more entry level jobs disappear, the less the next level up really understands what they're doing. Now that sounded dramatic, but I think it is. It's just we all do this, right? It's how you're teaching your kids math. Well, if they're using a calculator and they don't know how it actually works, right?
So do you think those entry-level jobs become, do you think those middle management jobs become entry-level then?
We could look at it that way, but I think it just steps up what's entry level, right?
Yeah.
You spoke a little bit about like the payment system with Medicaid changing, as well as the introduction of AI and like the introduction of bias with AI. Could you speak a little bit more to what the role of hospital systems is in addressing health disparities and the increase of those?
Tough one. Yeah, but you'd love it. It's question of whether it's a hospital's responsibility or sort of those, right? And you know, hospitals, they take a beating, and a lot of these are societal issues and more education than it is the hospitals. 501c3 hospitals, which are not-for-profit charitable organizations, have to take anybody. There's no distinction. Physicians can take, they could, you know, I actually have a friend who's an orthopedic surgeon, they don't take any Medicaid. Well, there's disparity. That's not the hospital's fault. I think it's an education issue, and unfortunately, I think most of our legislators don't understand how it really works. And so it's easy to make decisions that increase the disparities, lack of diversity. So I wish I had an answer to it. I don't. I think it's public education as much as possible.
What people are thinking about sort of societal obligation. What do you think about patient outcome when you make your client recommendations? What priority is that for you?
Patient outcomes, way near the top. I mean, it's all about quality and safety. And that's one of the wonderful things about Vizient is their data as measurements of quality as much as you measure, you know, and that is something we didn't have. And so you'd make decisions or recommendations on access and retention and evaluating where should we be, you know, sites of practice. And we didn't have that following on we do now. You know, this makes our recommendations way better.
Do you find it's like it's accurate? Do you find it's a good system to judge quality?
It's a good system. You know, is it accurate? You're always going to have, you know, differences, but I think it's way better than it was before, for sure. Now, one thing, there are different quality indicators that organizations buy. And if you're buying something, then people do have a vested interest. So if you're going to lean toward quality indicators, it should be, you know, somebody a little more objective than whether they're good.
You know, my sense is that the Vizient risk adjustment models and whatnot are sort of best of breed. And they're based on data that is more than just basic data, but you know, they'll look at things like speech and functional status and those kinds of things. So a lot of hospitals really do depend on it. And it's probably the best that's out there.
It is
my sense. So once we mean mental health,
oh my God, it's been wonderful.
Yeah.
What's the influence? Wonderful. Wonderful. It has, but again, back to what I said before, it's taken patients out of offices, physician offices, outpatient offices, and hospitals. But for patient care, it has become, it's amazing. And we should learn better how to do a little bit more of that. It's been especially wonderful. So one of my clients is Health Partners in Minneapolis. If anybody's from Minneapolis, and they're about $11 billion company, and they're 50% payer and 50% care delivery. And they use telemedicine because of the rural area around, you know, Minnesota, Dakotas, northern Wisconsin, and it's really, from a patient standpoint, awesome. So because you can get that care, now you have to be careful, right? You don't have to go too far with telemedicine within certain situations, but when you just need somebody to talk to, it's awesome.
my sense has been really very successful in behavioral health. Big time. In fact, we have alum who started companies, you know, that are in that space. that have been wildly successful because you're kind of breaking the capacity constraints.
Right, but also for Medicare.
Yep.
That's right. Also for Medicare, for elderly patients, it's much easier for them. Sometimes.
Yeah.
But what do you see the outlook for hospitals employing like advanced practitioners versus physicians in terms of like cost and availability?
Yeah, we've been focusing a lot on that lately, really having to change the care model of there's nothing, I mean, APPs can be, empowered to do more things and be more of a gatekeeper than the MD does. And there's a lot of movement toward maybe having medical school be 3 years instead of 4 years like it is overseas, and people are making faces to each other, but that's
We're all med students and we're doing 4 years.
well, there you go. There is a significant movement, and part of that is to keep the physicians from being burnt out. So instead, we're going to burn out the APP.
Yeah, but my sense is the hospitals don't really know how to best use the APPs yet. They're still experimenting with that. So, there's some evidence that they test more, they spend more time with the patients and those kinds of
They
things.
do spend more time.
Yeah.
But in theory, it's less costly time.
Yes,
right?
that would be the idea. That'd be the idea. Sure. Yeah.
For the last like 2 decades or so, there's been a lot of reporting on private equity owned hospitals and sort of the quality issues that they may have. As someone who has a better vantage point of this data, do you think that reporting is true? And what's your general outlook on the financialization of hospital systems?
I mean, for private equity owning hospitals, or for private equity taking pieces out of the hospitals?
Both.
So, as Dan said before, I mean, you don't find much private equity investing in hospitals. I mean, there are for-profit systems like HCA and Parsons and some of those. I would say the quality indicators are there. It's the patient experience that might not be the same. I think it would be death to private equity or the for-profit healthcare companies to sacrifice quality. But they do sacrifice on sort of patient experience. And the stuff that you get, and the number of people that might be paying attention to you when you're in the hospital or when you're having the procedure. So I'll give you an example. My son, when he was in high school, tore the labrum in his shoulder playing football and needed it to be reattached. And we did it at a standalone surgery center. Oh, it's no frills. You come in at such and such a time, and we take you in and we send you home, and you're a little wobbly. I mean, the safety was fine, but there wasn't a lot of people, running around and flurrying and here, take care of you and all that and feeling better. It was okay. It's 11 o'clock. It's time to go. Quality was great, did great, but they don't have the patient experience element that is where they fall behind.
But like hospital at home.
I'm hoping that there have to be more things. I know that a number of the large cancer research institutes are like Dana-Farber, Fred Hutchinson, Moffitt Cancer Center, Roswell Park, and they're all looking at how to do for their own, outpatient doing that now in a number of different places, but trying to get more comfortable with hospital situations where you have somebody who's really sick, right? But there's nothing you can really do about it. So how do you move those patients to a lower cost, more comfortable environment that's not quite hospice?
Seems like that's been stalled in Congress, right? It's kind of been on hold for waiting for this to be. I don't know. What are the pros and cons? But is there any tension around this? No, we don't know. Good question. Yeah.
I'm curious how you think about advising hospitals on
issuing debt securities, for instance, given that their cash flows have a lot of inherent reimbursement risk, payer mixes could change all the time.
It's that's what we do, a large piece of our business, and it really, that's why it bleeds into the whole financial plan, the strategic planner. And as you're looking at debt capacity, right? You do this on, you know, you're gonna go buy a condo, right? How much cash am I gonna put in? How much mortgage do I want to have? Well, what is my salary at risk? Do I have a salary plus a bonus? Am I going to borrow money based upon the bonus? And what if I don't have one? So these are all elements of the what if, right? What if things go wrong? At what level are you comfortable having that mortgage, having that debt? And there's a lot of it's a lot of scenario analysis, a lot of sensitivity analysis. So right now, right, we have federal government said we're gonna take $1 trillion out, and it's all gonna come into play a couple of years from now. And so a lot of organizations went, phew. And I'm like, what do you mean phew? We're gonna start thinking about that now, because changing hospitals like turning an aircraft carrier, they don't doesn't fill overnight. And what if you finish, you know, financing that patient tower you want to do, and 2 years from now, your state directed payments go away, or your Medicaid payments get cut in half? And can you still afford that, or do you have other sources of income that can support the payment of that debt? It's something that you shouldn't take lightly. It's a fixed cost. And the only way not to pay your debt service is basically file for bankruptcy and negotiate with the investors. So that's a pretty important topic.
Yeah, as the payer mix changes and our population ages more into Medicare and less commercial, how do you see hospitals adapting to the negative reimbursement pressure?
Well, that's what they're trying to do, and that's a lot of the planning, right? Is what solutions do we have as that component of the payer mix increases, as they use more and pay less. It's a great formula. So it is, then that's why, how do you decide patient access or the people who want to sit on their couch to get their healthcare, their pajamas? But those are the people that you have to try to bring into your sphere of influence to offset the increase in Medicare. It's all part of the solution set.
You briefly mentioned value-based care earlier. I was wondering if you could talk a bit more about how you expect that to evolve into us help.
Well, I always thought it was put before more value for, you know, getting more value for what you pay. That's value-based care. Linking all that together makes all the sense in the world. It has had a real hard time being adopted, right? There are some organizations that do it better than others, and I would say those are the ones that have a provider-sponsored health plan. So, like Health Partners that I mentioned, you know, they can focus on value-based care because they have both the financing component and the care delivery component, right? So you can link those together in terms of creating value for the payment, because both sides care, right? It's those that don't, and you have the Uniteds, the Blue Crosses, and you know, Aetnas, and everybody out there, and it's really hard to get them to care about each other. Basically.
So have we figured out what, but since we figured out what they do yet? No, we still don't know. Can you tell us who they are?
So that's the Verizon.
Verizon, yeah.
They are Kaiser, right?
Yeah, it's like Pfizer and then Geisinger, and then sort of.
Well, that was their first one.
Yeah.
Kaiser and Geisinger.
Yeah.
Right. So Verizon is this product of Kaiser that said we're gonna do joint things and make everything better. And I don't know how else to describe that. That's all I could tell.
Yeah, I know, when that merger happened, it was like,
I knew what they were doing, but I thought they're doing 5 years or anything different than it was.
I know.
before.
And interestingly, the CEO of is actually a Booth section. Well, so I'll ask him next time.
Yes, I'm said.
I'll ask him. Still. Anyway, okay, maybe time for one more question if anybody's got. Going.
Hey, let me ask a question. Are you all interested in healthcare? I know you guys are.
They're in medical school.
I know. So I think there are just, as I said, look around, be patient, talk to people. Like when I found my passion was healthcare, and then this particular application of corporate finance principles, because it was like looking at these organizations and saying, how are you thinking about this? And that was Booth, right? That was my background, specialized in hospital administration and concentration in finance. And so you look at these situations, you go, it's okay to question stuff. And listen to other people, listen to people at different firms. There are a lot of good places out there to go in consulting and just get some experience, right? And then you'll be able to figure out if you like that or you don't, right? You're not making a life decision right now. Just, I did. That was kind of weird. But yeah, it feels like it. But there are lots of different things out there that go consulting that you could do. Or you could go to a company or, go to Walgreens or something and become part of their healthcare arena or Amazon or something like that, and apply your skill set. But I think you have to think about, like I said, what risk you want to take and your appetite for that, and then what you like, because you gotta do it more hours a day than anything else.
How far is the Booth GSB Chicago been for you?
It's been great. As I said, I kind of owe my career to it. And, two of my partners, and we have a number of others, we did hire some Northwestern people. One others as well. And we had 700.
Yeah, you gotta lower the bar. Okay.
But it's really, anyway, there are all kinds of people who want to help you. All kinds of people in different walks of life and doing different things.
Yes.
And just reach out, and there's always somebody to talk to that'll give you their perspective.
Yeah, that's one of the great things about doing more at Booth with healthcare and the Tolan sector. And now we have a concentration, and so for students to be able to network with each other, get to know each other, who are moving on into healthcare, they pay dividends for many years to come.
Yep.
So anyway, thank you so much for speaking with us, and really enjoyed it. And
Good luck to all of you.